I've had many questions in the comments about, Doctor, I take this blood pressure medication or that one, and they'd like to know what the side effects are, if it's okay, and what effect it has. Well, in today's video, I'm going to explain a bit more for information. Mind you, this doesn't replace the dosage and prescription from the doctors who gave them to you. What I always recommend is to know more, to learn a bit more about health. And that's the idea of this video I'm bringing you today, to know which drugs you take, what their side effects might be, and thus be able to better treat your blood pressure. If you want to know this and many other interesting things, I recommend staying until the end of the video. So let's go. Right, the first thing I want you to keep in mind, just to give you an idea, is that the drugs one takes for blood pressure lower the systolic pressure. That's the first one, by an average of roughly 10 to 12 millimeters of mercury. This will depend a lot on race, age and combinations, but just to give you an idea. And the diastolic pressure by between 6 to 8 millimeters of mercury. So you'll realise why sometimes the dose needs to be increased, or medications combined to manage to maintain the ideal values, which, according to current recommendations, are less than 130/80. Now let's look at the groups of drugs so that you can recognise which of these you're taking. And if you experience any strange effect, you can say, it might be this medication, and talk to your doctor and say, Doctor, could it be because this thing here? Is there another option? That's the idea of the video, and for you to learn a bit more about looking after yourself. Right, here I'm putting the most commonly used pharmacological groups in green, and just so you know, the first three, which are diuretics, calcium antagonists, and ACE inhibitors / ARB2 receptor blockers, are the first regimens commonly used for managing blood pressure. You'll see that are the ones I'm gonna name, you're very likely taking one of them. And in first place we have ACE inhibitors and ARB2 receptor blockers. Simply put, there's an enzyme called the angiotensin converting enzyme, which through the action of different enzymatic molecules ends up acting at the level of the arteries on a receptor, causing the arteries to contract, and by contracting blood pressure increases. Then, on the other hand, they also increase secretion in the adrenal medulla and cortex of cortisol and especially aldosterone, which are substances that reabsorb sodium and water in the kidney, and this will also cause the arteries to increase blood pressure. Right, so these molecules are responsible for partially blocking the pathway, or these ones here, totally blocking the receptor. How are they known? ACE inhibitors end with the word pril. You'll recognise them as enalapril, captopril, lisinopril, perindopril. These are some of the best known, and you'll remember them by the word pril. That's an ACE inhibitor. And the ARB receptor blockers end with the word sartan. Sound familiar? Losartan, candesartan, valsartan, irbesartan. Those are some of them. These drugs are one of the first lines for high blood pressure, but you have to be very careful because, especially with ACE inhibitors, in 5 to 10% of cases they can cause a nocturnal cough. It catches you at night as the days go by and you start coughing with a characteristic dry cough. It's important that if there's no other cause and the doctor says, well, there's no other cause, sometimes the medication has to be stopped, and after about 2 weeks the effect passes, so it must be the fault of this one, and another alternative must be found. ARBs, on the other hand, have the advantage of not causing a cough, so sometimes they swap these for any of these over here. Be careful, these drugs should never be taken during pregnancy because they can cause kidney damage in the fetus, so they are contraindicated. Occasionally, when you have kidney impairment, you have to see how the doses are going because they could raise potassium levels. And you have to carry out strict monitoring when you have kidney problems. Mind you, not stones, but kidney failure problems. That's more or less the idea with these drugs, their most common adverse effects, raising potassium, caution with pregnancy, and the cough with ACE inhibitors. Let's move on to the others. Calcium channel blockers, which are very good medications, are more commonly used in old age because the arteries contract a lot due to the effect of calcium. They have a good effect at those ages, but they're used at any age. And calcium is a mechanism that acts in vasoconstriction, meaning the arteries close up, as we saw here with these receptors. So if we inhibit calcium, the arteries dilate. How will you recognize them? For the most part, a group of them ends in the word dipine. Amlodipine, felodipine, nicardipine. These are some that might sound familiar. These drugs here can mainly cause something called malleolar edema, which means your legs swell up. And mind you, it's such a common effect that sometimes we think it's because our kidneys or heart are failing, but it's actually the effect of the drug itself, which, by dilating the arteries in the lower limbs or in the legs, causes a little bit of fluid leakage and they swell up. Something that can be corrected with compression bandages or by raising your legs. And if the medication is doing you a lot of good, sometimes it's not necessary to change it. But if you can't tolerate it, it has to be modified. On rare occasions, it can cause reflex tachycardia, meaning your heart rate goes up without much explanation. Due to the same vasodilator effect, the heart can speed up sometimes, but the most common thing is for your legs to swell. Unlike verapamil and diltiazem, which act through another mechanism, but these, also at the heart level, these, unlike the others, lower the heart rate. So they're not recommended when you have heart blocks or very slow heart rates, or the heart is in heart failure, because they can worsen heart function. If you don't have that, they're very good, but if you do, you have to be very careful. And these here have an advantage that they don't cause reflex tachycardia, and both can cause constipation in some people. Very well. Let's move on to the third group of drugs, and here we have the diuretics. Sometimes there are people who are a bit afraid of diuretics and say, I'm going to urinate, dehydrate myself. But it shouldn't be like that. A well-controlled and optimized medication will generate a benefit. And we have, among the diuretics, the most common ones you'll probably know, the thiazide diuretics. Hydrochlorothiazide, chlorothiazide, the most common ones, sound familiar? They end with that word. And there are those that are called, which isn't quite right, but thiazide-like. That is, they act like these medications. What do? They make you urinate more, lose sodium, lose chlorine, a bit of potassium. We'll soon see some that don't make you lose potassium. They're called thiazide-like, but almost the same mechanism of action. There's chlorthalidone and indapamide. All of these belong to almost the same effect. As I said, their problems are that they can lower sodium a bit. It's good to check electrolytes every 3 months. How's the potassium? How's the chlorine? Sometimes they can cause a bit of dehydration, but if you're drinking enough fluid, that shouldn't happen. They're highly recommended when you have fluid retention because they're lowering your blood pressure and making you lose fluid. And some of them, for example these, can retain calcium. If you have low calcium, they help you. It'll depend on your condition if they use it or not. And these often come mixed with these over here, with the first ones. This group is mixed a lot with calcium antagonists, or these here. Seeing them combined with diuretics is the most common thing you'll find. And if you look at your medication, you'll say, well, this is the combination I have. Now, before moving on to another type of diuretics, I want you to tell me if you're liking this video, you're learning a lot, you're knowing a bit more about how your blood pressure treatment is, what adverse effects there can be. Leave me a like button here, share it, give it to other people, so this information can also help them and reach others. If you're learning and also feel grateful to the channel, hit the super thanks button or join as a member so I can see your questions or doubts more quickly and answer them. Let's go! Now, this diagram up to here shows the most common first-line drugs for arterial hypertension. But depending on whether there's resistance, if the values aren't controlled, we can add the ones we're going to see now. They're second line. Mind you, this second line status always depends on the patient's condition as well, and I'll tell you why in a moment. Potassium sparing drugs are a good option when this whole scheme of the first ones I mentioned doesn't work. And you have to introduce a drug called spironolactone, which is a diuretic that's not so strong, You lose fluid through urine, not as much as the first ones, but it retains potassium. Mind you, if you have advanced kidney failure or potassium problems, you have to be very careful because by retaining potassium, levels can rise, and high potassium isn't good. So if you notice, these ones flush out potassium, while these ones can retain it. Both make you urinate, this one a bit less. But a very important advantage is that also, if you don't have a problem with potassium, as I've told you, potassium is good for the arteries, it dilates them much better, and that's been seen to have a good long-term effect as an antihypertensive. That's why it's a good option when all of this fails. Now, here we have the adrenaline blockers. Remember that adrenaline is released in our body by the central nervous system and also by the adrenal cortex. What these hormones will do from the medulla and cortex, what they'll mainly do is bind to receptors called alpha and beta. And these receptors, the beta ones, act on the heart, the alpha ones mainly on the artery, causing the artery to contract. And the beta ones making the heart beat harder, pumping harder into the arteries, but also sometimes increasing the heart rate. That's what adrenaline does, which is why stress, anxiety, worry, raise your blood pressure, raise your heart rate. See? Very good. So these drugs are very good combinations or first line at times when, for example, you have chest pain from angina, or you have tachycardia or arrhythmias. Beta blockers, besides controlling blood pressure, help to lower the heart rate. That's why you see the heartbeat slow down. It improves angina, the chest pain. So, these can sometimes be first line when you have another condition, an arrhythmia, coronary problems. So you always have to keep that in mind because maybe they give it to you right away. How will you recognize them? Because they end with the word ol. Atenolol, bisoprolol, carvedilol, metoprolol, propranolol are some of them. And these drugs mainly block the beta receptors, the cardiac ones. Some also have an effect on the arteries, such as carvedilol, which can dilate them because they act on both receptors. But watch out, be careful there. Beta receptors are also found in the bronchial tubes. And when they're non-selective, drugs that only act on a receptor called beta-1, which is only in the heart, there are some that act on both beta-1 and beta-2, blocking them. What happens with this? Well, there are beta receptors in the bronchi. When we block them, if, for example, I'm asthmatic or have chronic lung disease, giving these beta blockers can cause more bronchoconstriction and exacerbate asthma attacks or shortness of breath. So you have to be a bit careful with these drugs in bronchial conditions and look for selective ones like bisoprolol, atenolol or metoprolol so as not to affect those other bronchial receptors, but that's for the doctor to decide. These drugs can often, the younger you are, cause sleep disturbances. Some might feel fatigued initially, insomnia, erectile dysfunction, circulatory issues, or effects on diabetes, like raising glucose. They also cause bradycardia. As I said, they lower the heart rate, and if you have an advanced heart block or a very slow heart rate, you have to be monitored closely. It depends, as always, on the specialist's assessment. So you have to consider those effects when taking these medicines and know that many of them can disappear with daily use or become tolerable and provide a good benefit. Now, finally, to finish off, we have the alpha blockers. And alpha blockers, as the name suggests, block the alpha receptor. An alpha-1 receptor that's right in the arteries, and they contract with that receptor. We'd already seen this one here, and we'd seen that one there. We have the alpha. By blocking alpha-1, what do? The arteries dilate. How are these drugs known? They end with the word ozin, doxazosine, tamsulosin, prazosin. Those are some of them. And with these drugs, you have to keep in mind that although they lower blood pressure quite a bit, sometimes when nothing else has worked, they can cause fluid retention. They're not highly recommended for people with heart failure, they're not prescribed as a first-line treatment, but on the other hand, they also relax the muscles around the prostate. That's why some of your men will recognize these medicines, because they're used for the prostate. Because by relaxing the prostate muscles, they can urinate more easily. So you think, well, if I have a prostate problem and high blood pressure, these might be the drugs of choice. That's very important to know. But on the other hand, watch out the first time you take this type of medicine, be careful on the first day. It has a first day effect. What is it? If you stand up quickly after taking one of these medications, your blood pressure can drop significantly, causing orthostatic hypertension, dizziness, or even fainting. So be careful with the first dose, the very first time you take it, especially with these specific medications. And that's it. These are the antihypertensive drugs generally used as first line or second line treatments depending on the conditions. The goal is to lower your blood pressure to less than 130/80. The choice of medication depends heavily on whether you have hypertension with diabetes, kidney issues, cerebrovascular problems, or peripheral circulation issues. That's where the art of medicine comes in, to find the ideal combination for you at the right dose so you can tolerate it, take it easily, and keep your blood pressure low, and thereby prevent many diseases that can develop over time. And this was a video about antihypertensive drugs, a bit long, but I truly believe it will help many, since I get lots of questions on this topic, like if this one's better or that one, or what I think about certain side effects. I believe this video is informative, but as I said, it doesn't replace a medical consultation. The idea is for you to understand your health better and know exactly what you're taking. And if you liked it and want to know about any other medications, let me know in the comments section. Tell me, doctor, what do you think? And we'll see about making another video. Also, if you want to find me and learn other things on the social media as Dr. Ricardo on TikTok and Instagram. And if you need medical attention, a consultation, or perhaps a clinical assessment of something you're taking, you know where to find me at www.drricardofreile.com. And without further ado, I'm thanking you for the time you spent here. You mustn't forget that this is what your heart needs.